Hi, my name is Dr. Ahmad. I'm a PGY2 internal medicine resident at Manatee Memorial Hospital located in Bradenton, Florida. I want to thank you for your interest in our case presentation and poster titled Clinical Dilemma and Equipoise of Anti-N-methyl D-aspartate receptor encephalitis associated with ovarian teratoma. The pathophysiology of anti-NMDA receptor encephalitis is the paraneoplastic production of autoantibodies that bind to and attack the NMDA receptors found on neuronal tissue. The most common etiology for this paraneoplastic production is an ovarian teratoma. However, there have been reports of associated testicular germ cell tumors, mediastinal teratomas, small cell carcinoma of the lung, Hodgkin's lymphoma, and ovarian cyst adenofibromas as the cause for the production of these autoantibodies. The clinical symptoms of anti-NMDA receptor encephalitis are diverse, making diagnosis a challenge. Patients can present with psychiatric symptoms, including hallucinations, delusions, and disorganized thought, along with anxiety and agitation. Patients can also present with ongoing memory issues, issues with sleep, causing insomnia, and have issues with seizures. Patients can have paroxysms of catatonia, chorioathetosis, and dystonia. Autonomic instability is also common, leading to fluctuations in blood pressure, heart rate, temperature, as well as respiratory status, potentially leading to hypoventilation. Finally, patients can also develop language dysfunction, leading to mutism, echolalia, and reduced language output. MRI can be normal in these patients, or it can display hippocampal lesions, which portends a poor prognosis. CSF can be normal, or lumbar puncture can show elevated protein levels, increased CSF opening pressure, or can display a lymphocytic pleocytosis. Definitive diagnosis of anti-NMDA receptor encephalitis involves CSF with the presence of said anti-NMDA receptor antibodies. Our patient is a 34-year-old female with a past medical history of panic attacks, anxiety, depression, lumbago, and substance abuse, who was brought to the ED by her husband for worsening mental status changes and worsening agitation. The patient reported that her symptoms had started about a week prior to admission with auditory hallucinations, wherein the patient reported her husband that she was hearing parts of a TV show that she had watched a couple months ago. The husband also noted that the patient was having ongoing, increasingly violent behavior and that the patient had not been getting any sleep. On admission to the hospital, the husband did note that the patient had been recently prescribed orphanedrine for issues with back pain, and he did admit that the patient had been smoking K2/spice and had been taking chronic benzodiazepine for ongoing issues with anxiety. In the ED, the patient exhibited severe agitation and self-harm behavior, including banging her head against the walls and the windows despite frequent reorientation and sedative medications. Eventually, the patient was sedated and intubated for her own protection and was transferred to the ICU for continued care. Throughout her hospitalization, the patient showed fluctuations in mental status ranging from catatonia with facial muscle twitching to severe agitation to apparent seizures. EEG obtained throughout hospitalization showed no evidence of seizure activity. She was under the care of a multidisciplinary team, including critical care, neurology, psychiatry, and the internal medicine residency team. Of note, during her hospitalization, her family arranged for multiple exorcisms, which brought no benefit. Her CSF studies were unrevealing for infectious etiology, but eventually her CSF anti-NMDA receptor antibody did come back positive at a high 1 to 160 titer. With this information, we started the patient on plasma exchange and started the patient on a 5-day course of 1 gram of solumedrol. We ordered a transvaginal ultrasound, which did demonstrate evidence of an ovarian teratoma. A follow-up MRI of the pelvis with or without contrast, which can be seen in image A, did demonstrate a right-sided ovarian mass measuring about 1.2 centimeters. We consulted gynecological surgery for removal of this mass. Histology reports seen in image B and image C confirmed that the mass was indeed a teratoma. The patient did improve with our medical management, particularly with removal of the paraneoplastic nidus. She was eventually discharged to LTAC after 49 days of inpatient care, displaying persistent retrograde and anterograde amnesia. Fortunately, despite her prolonged hospitalization, the patient's neurological symptoms and functional status have improved. Per conversations with her husband, the patient is displaying abilities to perform her ADLs, including showering on her own and putting her own clothes on. She is, however, still having issues with performing IADLs and is unable to cook for herself and unable to drive. The patient has not returned back to work due to ongoing issues with lower extremity weakness, but the husband is optimistic that the patient will continue to recover. We postulate that many of her symptoms from her past medical history are associated with this underlying anti-NMDA receptor encephalitis. We also recognize that orphanadrine, the medication that was prescribed for her ongoing lumbago, acted to exacerbate her underlying anti-NMDA receptor encephalitis disease process. Orphanadrine has NMDA receptor antagonism as its mechanism of action. Several other medications also act to antagonize the NMDA receptor, including PCP, ketamine, and memantine. Memantine is particularly used commonly in the treatment of dementia and Alzheimer's disease, and thus requires extra surveillance. We note that anti-NMDA receptor encephalitis is a potentially treatable form of neuropsychiatric disease processes and requires a high index of clinical suspicion for early diagnosis. We hope that with this presentation, we can increase the awareness of this rare illness, and we hope that future patients can have early diagnosis to reduce ongoing morbidity and mortality. We would like to thank you for your time and your interest in our case presentation.